Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today we hear from Dr. Kelly Ridley, an addiction psychiatrist who discusses treating nicotine dependence with Dr. Olga Ward.
Kelly, welcome to the program.
Thank you.
Now, you're a psychiatrist down in the Great Southern, and today we're going to talk about smoking, which doesn't, on the face of it, seem like part of a psychiatrist's job description. And I know GPs find it so difficult to support patients who would like to give up smoking, or at least are in love with the concept of maybe not being a smoker, but really the reality is this is a horribly addictive drug. How do you tackle this one?
Well, it's straightforward if you know what you're doing, but I think the problem is that none of us get taught this. You don't get taught it if you're a psychiatrist. You don't really get taught it if you're a GP either. And I think there's still a bit of a myth that smoking's a lifestyle choice. If you really wanted to, you could quit, you could do it on your own. And so we tell our patients, I think you should stop smoking, but we don't necessarily know how to take that next step in helping them stop. So the public health physicians and the public health campaigns have been brilliant. So in 1980, about a quarter of the population smoked, and then we did plain packaging and we did tax increases, and now about 11% of Australians smoke. So we've tackled a lot of stopping people smoking in the first place, but it means that the people who are still smoking now are high-dose nicotine dependent. They're the people who it is going to be really hard to stop smoking off their own back if we don't do something specifically to help them. Yeah,
and I find a lot of them are mental health patients as well.
Yeah, absolutely. So the more serious your mental illness, the more likely you are to smoke. So on inpatient units, back when you could smoke on inpatient units, the smoking rates were up to 90%, up to 60% of people with schizophrenia smoke, and those rates haven't been improved whatsoever with the public health prevention campaigns.
So what is with that?
It's almost certainly shared genetics, particularly with schizophrenia and smoking.
Is it a dependency thing?
No, there's been at least 20 genes specifically linked with shared genes with smoking and schizophrenia. So the other side of it as well is what people gain from nicotine specifically. So nicotine is a stimulant, but it's also a calmative, it's an appetite suppressant, and it increases your concentration. So that's what lots of people would love for me to be able to give them from a pill. It's what they're seeking out, and they can get it in a convenient stick form 20 times a day. So nicotine is useful for people with mental illness. But also there's the other aspects of cigarettes, which is the polycyclic aromatic hydrocarbons. And those portions of a cigarette can actually lower the levels of different drugs, particularly antipsychotics, in the body. So lots of people would like to be on lower doses of medications or get side effects from medications, and they're finding something that will do that naturally. So there's lots of reasons why, say, someone with schizophrenia on olanzapine or clozapine might continue to smoke cigarettes.
I hadn't really thought about the medication aspect of it.
Yeah.
So always in the back of your mind then, if they do manage to quit smoking, you're thinking, oh crumbs, now I'm going to have to put their olanzapine dose up.
No, I'll put their olanzapine dose down. So smoking cigarettes lowers people's blood levels of a medication. So if they are able to stop smoking, I can lower their dose, and I use that as a hook. Do you want to be on less medication or get more bang for your buck from this medication? Let's target your smoking.
So that is a good thing to remember. I was understanding from what you said before that some of the substances in the nicotine were acting in the same way as the olanzapine, for instance, might be.
Directly acting on its metabolism. So I'm not explaining myself very well.
No, that's just fine. That's we've got that one super clear now. So how do you actually tackle supporting the patients? I mean, GPs are really good at bringing it up.
Yeah.
And then we, as you said, we don't know where to take the next step.
Yeah. So the first step is really hooking someone in, and the biggest hook I find is the money. So if you smoke a pack a day, it's about $12,000 a year. If you're on the disability support pension and you smoke a pack a day, it's a third or more of your income. And so I frankly ask people, if I know they smoke cigarettes, shall we try and save you some money? It's not usually the health impacts that are things that will draw people in. Everyone knows that smoking's bad for your health. So I go for the money, or I go for the medication aspect of it. And then I say, I have a whole range of things that I can offer you. Different medicines that you can take in different forms. We can look at patterns of behaviour and address those, or we can get the most bang for our buck and do all of those things at the same time. I also don't talk to patients about quitting, because every smoker has tried to quit, and most of them many, many times, and they've failed. So if I say, do you want to quit? Most people say, no, thank you, because the experience of trying to quit is the experience of failing. So I use language like, shall we try to address your smoking? Can we take some control back over your smoking? Because that's what people want. They want to have some choice about how much they smoke and when and where.
Yep. Okay. And then most of us have, with the patients at one stage or other, tried nicotine replacement and the various medications which are marketed as Zyban and Champix. I also find that many of the patients say, oh, that stuff just sent me loopy, or they're really worried that it's going to interact with their concurrent antidepressant. How do you kind of work your way around that?
Yeah, so I guess I'll answer that in two aspects. The first one's around the nicotine, because I hear that a lot. I've tried the patches, they did nothing. And they're not doing nothing, but people are right.
They're a very low dose.
They are a very low dose. So a dependent smoker has a plasma nicotine level of around 35 nanograms per mil or more. And people who are high dose nicotine dependent are sitting at 70, 80, 90 nanograms per mil of nicotine in their blood. The strongest patch we have gives you 10 nanograms per mil. So if you slap a patch on, okay, it is doing something, it's not doing nothing. But realistically, people might need multiple patches, and they certainly need a patch plus some gum, lozenges, inhalator, mist spray, or a combination thereof, to get to a level that it's actually going to be when they can feel it, and it will be easier to make changes to their smoking. The other side of things that you mentioned was the Champix, and it's sending people loopy.
Yep.
And there is a lot of myths around Champix. And Champix is a safe and effective drug if it's used safely.
Yep.
And it's a really genetic crapshoot. So some of us have nicotine receptors. When Champix comes in, it binds it and it activates it. For those people, they get all the benefits of having their nicotine receptors full and active, all the benefits of nicotine. But if they smoke, because the receptors are full, they're not getting any additional benefit. So you're feeling good because your nicotine receptors are full, and you get no benefit from smoking more. So why would you smoke on top of you? And for those people, they say it's a wonder drug. Thank you, doctor, you have cured me. Unfortunately, that's not everyone, because of whatever lovely lottery in genetics. When Champix comes along for those people, it still binds to their nicotine receptor and fills it, but it doesn't activate it. So in essence, those people are in nicotine withdrawal, with all the resultant irritability, appetite disturbance, anxiety, insomnia. And if you smoke on top, you can't overcome it because your receptors are still full.
Of course.
And it feels awful. And the advice used to be from well-meaning but misinformed doctors, oh, keep going, keep with the Champix. And if you're not sleeping and you're having trouble eating and you're feeling really anxious, particularly if you have schizophrenia, bipolar, anxiety, depression, that is going to send you off the deep end. You're going to feel terrible, and that's why there was adverse outcomes from Champix. It's not that Champix itself makes people mentally unwell, but it can, through its actions, put people into nicotine withdrawal. So you'll know that within somewhere between 4 and 7 days. And I tell patients, if it's making you feel terrible, throw it away, never try it again. Your genetics will never change. This is not the medicine for you, but do not persist with it if you're feeling bad.
Yeah. And alternatives for those patients?
So NRT in combination or one form or another, or there's Zyban, which is bupropion. That's an antidepressant it's an antidepressant everywhere, but it's a very popular antidepressant in the United States. Its odds ratio for helping someone stop smoking is not as good as Champix. It's about 1.5, but it does have some effect for some people. It also potentially comes with some side effects like nausea and dizziness, like all medications potentially have, but it is another option. Whereas nicotine replacement is safe and tolerable for the vast majority of people out there. And you can use quite heroic doses of nicotine replacement. Your body will naturally tell you if you have too much by making you feel a little bit sick when you have either a puff on a cigarette or a gum or a lozenge or something like that.
Now, if you had a patient who's done really well on Champix, can you keep it going longer than 3 months if you need to?
You can. Eventually your PBS funding will run out.
Yeah.
But actually the longer people are on it, the more chance they have of making a lasting change, because it gets people out of some of the habitual aspects of smoking. It's the behavioural changes of, okay, I don't even think anymore about having a cigarette with my morning tea or things like that. Just the habits people build up over years, and they stop associating parts of the house or the workplace or the car with smoking, and those cues become less over time. The other option, of course, is if people happen to have a lapse or a relapse back to smoking, they can always go back to Champix. If it worked for you before, it will work again. It doesn't wear off or anything like that.
Yep, sounds good. Vaping's really popular.
It is.
Where do you see that as a role in helping patients with their nicotine dependence or controlling it?
Yeah, so I think it's a second line option. I'd never suggest it off the bat as the first thing for a patient, but lots of people come to me and say, what do you think about vaping? Often because they already have started vaping. And it is a very good harm minimisation tool. So vaping's been around for about 20 years. So if it was going to have short to medium term effects, we would have seen it. Will it have effects on people in 30, 40, 50 years? Perhaps. But the perhaps mostly comes from the additives, the flavourings and colourings that are added to some nicotine vape juice. Nicotine in and of itself has been around for hundreds of years. We know what nicotine does. It's safe to vape nicotine. So I tell patients, know what's in your vape juice and buy from a pharmacy or a reputable source your vape juice and your vape unit. You don't want the cheapest model you can possibly get off the internet. You don't know what they're made with, what metals they're made with. You don't know whether they're going to explode. The big change with vaping is from the 1st of October this year, the TGA regulations are going to change. It's going to bring all the states and territories into line, which at the moment all the regulations are quite different, where you can someone can come into your GP practice or psychiatry office or wherever you may work and say, I would like to be prescribed a vape unit and vape juice. And you can write a script for that. They can take it to a pharmacy and they will know what they're getting. So you'll be able to prescribe vaping in the safest way we possibly can.
That sounds like a good thing.
It is.
What about the other kinds of supports? I know there's lots of kind of quit smoking support groups and psychology sessions and hypnotherapy sessions and other things that are available in major cities. Our patients, when a GP is prescribing something like Champix, we're supposed to refer the patient to some kind of support group or support service, and that is the Quitline or the Quitline. Is there anything else out there for rural patients?
It's largely online-based resources. So counsellingonline.org.au is a general addiction support service that has sort of written information, or you can interact with people on email or chat or call them as well. Quitline, while I don't love the name because I don't like the word quit, is a good service that's been around for a long time, and they also have apps and online resources. So does the Cancer Council of WA. But in terms of face-to-face support, it is really limited in rural places. In the Great Southern, where I work, we have a smokers clinic for our mental health clients that a doctor runs. They also have one in Broome, and we're getting them started across wax, so watch this space in other areas. But also, if GPs individually would like to get some information about some of the behavioural or brief psychological interventions around smoking, because there are a number of them and they have good evidence, they can get in touch with me directly. I'm happy to train anyone up. But I can also get people in touch with resources around things like urge surfing, the 3Ds, cue avoidance and things like that.
That sounds good. And you're on the Health WA Global email?
Sure am. There is also a number of videos of me on YouTube talking about smoking, including some of the behavioural interventions.
That'll be great. Well, I'm hoping to be able to get started with supporting some of my patients a bit more.
I love it.
Thanks, Kelly.
Thank you.